My topic is really to cover in the next 30 minutes all the issues around HIV and hepatitis C co-infection. So you can see I have a whole range of different things I want to cover, and I hope I make it in the 30 minutes. So the first is obviously all around the diagnosis of acute and chronic hepatitis C, just reminding you all that the presence of antibodies is indicative of either resolved or chronic hepatitis C, and in order to determine whether it's really chronic, you will have to do an RNA test. So remember that hepatitis C can spontaneously resolve in a certain amount of patients. Usually in the setting of HIV co-infection, this is somewhat lower, of only 15%. Otherwise, it's probably 25%. And in the setting of symptomatic acute hepatitis C, it's probably 50%. Now, one important thing, and that's why I included the diagnostics here, is that in the setting of HIV can actually take quite a while to develop hepatitis C antibodies. So in the setting of new onset of elevated liver enzymes, be well aware that it can take up to 12 months before antibodies develop, so you really have to then perform hepatitis C RNA in order not to miss the diagnosis. And also remember that there are patients who actually become negative at month 6 after infection. So you would think that they're resolving infection, but actually some of them then go on to redevelop viremia as a sign of persistent chronic infection, probably because the immune system is just not strong enough to clear infection. Looking at the epidemiology, I think it's important to highlight that there is considerable overlap between HIV and hepatitis C for shared transmission pathways, and that's obviously particularly true in the setting of IV drug users, where probably around 80% of patients who have HIV also have hepatitis C. There is an increase in infections now in men who have sex with men and far less in other risk groups for HIV transmission. The epidemiology of hepatitis C and HIV in the European setting is really characterized by what risk factor drives the HIV epidemic. So particularly in Eastern and Central Europe, you will see very high co-infection rates, so Ukraine and Russia, where IV drug use is the main driver of the HIV epidemic. You can find 50, 60, or 70% of patients having HIV and hepatitis C. In countries where MSM is the main driver of the HIV epidemic, like Germany or the Scandinavian countries, you'll find much lower transmission pathways, much lower co-infection rates of only probably around 15%. Now, of note, in the southern European countries, Spain, Portugal, and Italy, in the beginning of the HIV epidemic, this was also driven by IV drug use, and you had high co-infection rates of probably almost 50%. With introduction of syringe exchange, clean needles, methadone substitution, that has dramatically decreased. The amount of new infections is very low, and so by now it's only around 25% of co-infection in those countries, where now MSM have taken over large parts of the new infections. This slide summarizes the outbreaks of acute hepatitis C reported in literature, and you really can see that this is something which has spread over the last years to many different regions of the world. Phylogenetically, these infections are not linked, so you find different genotypes in the various regions, just telling us that something's happening worldwide, pretty much at different time points with different genotypes, but really occurring in the same group of MSM, and really, I think, making a pledge for thinking of how can we best prevent that happening in other places as well. You've been introduced to the variety of different hepatitis C genotypes and how they are distributed in various regions of the world, so I'll skip that part. It's just important to note that obviously there is a wide distribution, which means that we need targeted therapy for the various genotypes which can be found. Now, the goal of hepatitis C therapy is what we call sustained virologic response, so that's an undetectable hepatitis C RNA 12 to 24 weeks after treatment completion. And it's important to really remember that that is sort of very different than what you heard to HBV or to HIV talks and all the difficulties and challenges in the cure agenda, because here really, if you have lost your hepatitis C RNA at these time points, you are very likely to have cure of hepatitis C, but it does not lead to protective immunity, so you always are prone to potential reinfection. Now, the importance of understanding why we want to treat hepatitis C is obviously linked to what changes if we do treat, and what benefit can we promise payers who have to sort of pay the high prices associated with these therapies. So it's important to look at some of the cohort data which shows what is the impact of achieving SVR. And this is probably one of the first large studies looking at mostly patients with advanced fibrosis and cirrhosis, and the changes of patients who achieved SVR under interferon ribavirin therapies. And you can see there is a dramatic reduction in liver-related mortality and the likelihood of developing liver cancer. And that is sort of the justification of why you would want to treat patients. I think more importantly, though, as things are progressing and we're thinking of who we should all treat, we're also beginning to understand that achieving cure of hepatitis C is also associated with a reduction in all-cause mortality. And I think very much in parallel to HIV, where we think that chronic infection, even the setting of controlled viral replication, is a stimulus to the immune system to induce an inflammation-associated response. For chronic hepatitis C, I think we must postulate and presume the same thing. So even in the absence of progressive fibrosis, you will have an immune response which is associated with inflammation, and inflammation along the blood vessels obviously can lead to atherosclerosis and thereby enhance cardiovascular mortality. And indeed, stroke and myocardial infarction seems to be enriched and increased in patients with chronic hepatitis C. So the overall reduction in all-cause mortality, I think, is most likely to reflect changes along cardiovascular morbidity. Keep in mind that hepatitis C also induces insulin resistance, which further can contribute to cardiovascular complications. In the setting of co-infection, very nice work has been done in a very large cohort collaboration effort. Over 3,500 patients. To date, the largest cohort which has addressed the impact of SVR on subsequent hard clinical endpoints. And you see that the risk of liver-related death after hepatitis C therapy is much lower in those patients who achieve cure under PEG-RIBA therapy. And most interesting, this is also repeating the aspect of all-cause mortality, which is improved in those patients who achieve SVR. So again, telling us that beyond clinical endpoints regarding liver disease, you will also have an overall survival benefit by achieving SVR, which I think is the first strong reason why you want to treat independent of fibrosis stage. So why do we pay so much attention to hepatitis C in the setting of HIV? What makes this particularly special? Well, obviously, with the onset of antiviral therapy, achieving long-term suppression, we had to observe in our cohorts that actually the presence of hepatitis C antibodies already alone are associated with a dramatic increase in the probability of dying from liver disease. Obviously, that is even higher in those patients who have antibodies and are replicating, really reminding us that liver disease takes a more unfavorable course in the setting of HIV. And that has been nicely shown also in a more recent analysis, again from the EuroCEDAR cohort, where you see the strongest incidence of liver-related death in patients who have more than F2 stage fibrosis and a low CD4 count. So it's important to remember that the main driver of fibrosis progression in the setting of HIV are patients who develop significant immunodeficiency. So if you would summarize the hallmarks of co-infection, it really would be the enrichment with regard to the epidemiology, so the prevalence is higher, particularly in the IV drug users, more recent in the MSM population. Patients on average, because of a lack of immune control, have a higher hepatitis C viral load. That was meaningful in the old days with PEG and RIBA because you were then less likely to respond with high baseline viremia. It may have an impact on infectivity, and there have been reports suggesting that there is a higher mother-to-child transmission, for example, and also an increased risk of sexual transmission. The likelihood of spontaneous clearance is somewhat lower. It's only around 15%. And again, the progression to hepatic fibrosis is clearly enhanced. The probability of developing cirrhosis is increased. And as such, sequelae of liver disease, hepatic decompensation, liver cancer, and eventually dying from liver disease are found more frequently in this patient population. So that's why, in the end, you want to treat your hepatitis C HIV co-infected individual. Now, in the recent years, a lot of effort and thinking has been around what is the optimal treatment strategy. Would you treat hepatitis C first, treat HIV first? Can you treat them at the same time? Well, obviously, under consideration and reflection of the crucial role of CD4 count levels in driving fibrosis progression, there always has been an urge to treat hepatitis C infected patients earlier, and this is from the old EX guidelines recommending earlier treatment initiation in those patients who have hepatitis C. It's also true for those who have hepatitis B. But obviously then when the STAR trial results were publicized for the first time and the subsequent guidelines have initiated now recommendations which strongly encourage people to start HIV therapy in everyone independent of CD4 cell count, that sort of makes this true for co-infected patients as well, so we no longer need special initiation guidelines because obviously now everyone with HIV diagnosis should receive treatment. That also, I think, sort of determines the order of events, so you would rather want to treat HIV first, make sure that the CD4 count starts to increase, viral load is suppressed, and then start your hepatitis C therapy. The impact of HIV therapy on the further course of liver disease has been shown in numerous studies, and this is one of the more recent examples looking at a very large sample size of over 10,000 co-infected individuals from the Veterans Cohort study. And what you see is that initiation of HIV therapy reduced the rate of hepatic decompensation and really tells you that if you can keep CD4 count levels up, you really have a very strong benefit, which is important if you have no access to DA therapy because that means you can still do something good for your patient until those drugs become available. Now, the logical next thing to think about is if you can sort of delay fibrosis progression by preserving high CD4 count, couldn't that eventually mean that your course of liver disease transcends into the similar course of mono-infected patients? So the Veterans Court addressed this question in a very nice analysis with large patient numbers, comparing 6,000 mono-infected patients with 4,000 co-infected patients who were on HIV therapy. And to their surprise, they still found a 1.5-fold higher risk of hepatic decompensation, suggesting that maybe HIV does contribute to a faster fibrosis progression, even in the setting of receiving HIV therapy. However, if you go into the details of the paper and look into the sub-analysis, you will see that this is really enhanced, particularly in those who either are still replicating under HIV therapy, so not sufficiently controlled under the regimen, or those patients who really started HIV therapy very late and have a discordant response and the CD4 count is not above 200, suggesting that if that CD4 count has been low for a while, they already have developed significant fibrosis and obviously are more prone to develop hepatic decompensation. So what that tells you is that if in the START era we now start everyone early and no one ever has a CD4 count below 500, would that then be different? And I think that is still out there to be examined in further cohort studies. I think one of the fascinating stories of hepatitis C and HIV and the diminished immune response against hepatitis C is reflected in several very nice immunology papers, and this is just one sort of a case report of 3 cases from a large Swedish cohort of co-infected individuals where they identified 3 patients who were actually able to spontaneously clear a hepatitis C infection after starting of HIV therapy. So by starting HIV therapy, immune reconstitution, they enhanced their response against hepatitis C. There are nice ELISpot studies showing that there's actually a better CD8 response, and then they eventually cleared. All of these patients were IL-28BCC genotype positive, which is interesting because those patients are the ones who mostly spontaneously can control their infection. So it sort of really nicely reinforces that if you get your immune system restored, you may actually then become able to lose your hepatitis C. That's important from a clinical perspective because you may have patients when you start HIV therapy where the liver enzymes normalize, and then you do want to do your RNA test because maybe the patient's clear infection and then would not need this relatively expensive hepatitis C therapy. Now, one word to monitoring under hepatitis C therapy, and I think that's important because we're coming from the PEC-RIBA era where the most important marker of treatment success was really viral load at week 4, right? So if you were negative at week 4, you were very highly likely to respond to interferon-based therapies. Plus, it gave you sort of a hint of how long you should treat your respective individual. In the setting of DA therapy, this has all changed. All patients become negative at week 12, if that's the sort of usual treatment duration. But there are some patients who display, depending on which viral load assay you use, they are sort of below the limit of detection, but still have target detected. And in the old days of interferon ribavirin, that usually meant that these patients were prone to relapse. This, however, and this is taken from 2 co-infection trials from the NIH, where you can see that there was a considerable amount of patients who at the end of treatment still had target detected but were under the quantification limit, and all of these patients went on to clear infection. So viral measurements during DA therapy don't say anything about your outcome, and there's no reason to prolong therapy because you're still replicating at very low quantities at week 4 or even at the end of treatment, because this is not predictive necessarily of relapse. So that's something different, and I think it's important because it does save money for monitoring on your way to treatment success. Who should we treat? We already saw that in the context of monoinfection, and really the same rules sort of apply. In general, treatment is recommended for anyone who has chronic replicating hepatitis C. There's a prioritization for higher fibrosis stages. And I think the ASLD, which is a little bit more updated, the EASL guidelines, will find a new version in probably July, August of this year. You can see that actually now every patient is considered for treatment, and I think that's important to remember. So how has hepatitis C therapy changed? You already saw this sort of rainbow diagram, which showed you the sort of very dismal 6% in the very beginning of giving non-modified interferon thrice weekly, and how that all increased up to the over 95% we have become so familiar with now under oral DA combination therapy. And I think the most important thing is that in the setting of HIV and hepatitis C, response rates to PEG and RIBA always were somewhat lower. On average, it was less than 30% in patients with genotype 1 infection. Remember, that was around 50% for monoinfected patients, and that has been a reason why in many parts of the world, hepatitis C therapy had not had a great uptake in co-infected individuals. In the US, on average, it's like 10 to 15% less uptake in the setting of co-infection because of that relatively dismal overall response rate. Once DAs were introduced, you can see this here for the boceprevir and tenofovir plus PEG-RIBA combinations, you suddenly had those around 74% response rates, which are very much superimposable to the overall cure rates in monoinfection, and then with the all orals, the same kind of response rates have been achieved in co-infected individuals, and I think that's a great step forward because obviously that means that we now can apply the same sort of standard rules and considerations of hepatitis C therapy for those patients who have HIV and hepatitis C co-infection. This is the schematic life cycle, and you have seen the various drug classes and intervention steps just as a rule of thumb to make this increasing sort of drugs which have become available a little bit more recognizable. Always remember that the protease inhibitors end with a Previr, the NS5A inhibitors end with an Asvir, and the NS5B inhibitors end with a Buvir, so you sort of have a little separation rule. At least you know what are the people talking of when you think of all these different various compounds. Now, the only thing which remains special for the co-infection population is obviously the need to treat HIV, and as such, you're giving drugs which are commonly, in many cases at least, metabolized by the cytochrome P450 system, as such prone to cause drug interactions, as many of the hepatitis C drugs are using the same metabolization pathways. Remember also that there are interactions with renal transporters, so that's another mechanism, or PGP, which can sort of cause interactions. So you really have to look up on a drug interaction website the respective drug interactions. Obviously, if you have an HIV protease inhibitor, you're very prone to interact with hepatitis C protease inhibitors. Usually protease inhibitors mean that you enhance drug levels. Enhanced drug levels usually comes with more toxicity, and that may be a reason for not being able to combine those agents. If you use efavirenz, remember efavirenz can induce the cytochrome P450 system, you make it subtherapeutic levels, and that eventually can lead to drug failure. So that's sort of really important, and I'll walk you through some of these issues. I think, though, that although particularly in the beginning when we only had boceprevir, tenofovir, which were both PIs, and as such were prone to have many drug interactions, we now do have a lot of alternative regimens for treatment of hepatitis C as well as for HIV, and so actually it's become much easier to select corresponding components. Integrase inhibitors, which are not boosted baltegravir, dolutegravir, are both combinable with all hepatitis C drugs. You see it's all green. So that's a very easy way forward. Unfortunately, the price, though, of these compounds is much higher in many countries, and sort of that is sort of making it somewhat difficult to use them exclusively. Also, remember that it will depend on your baseline resistance. So if you have a patient who has 30 years of drug experience and already has accumulated mutations, you cannot just easily switch them to a different integrase-based regimen, so that's something to keep in mind. With regards to the NRTI backbone, everything works pretty well. The only thing to consider is that tenofovir levels increase in combination with ladipasvir. So if you have a boosted PI and then give ladipasvir and tenofovir, you may have very high tenofovir levels, and that may warrant either more renal monitoring or actually may even prompt the question of ART adaptation. With regards to the NNRTIs, I think rilpivirine has the lowest potential for drug interaction, so there seems to be a way through for most of the compounds. But for efavirenz, particularly with protease inhibitors, that can be difficult. And then if you have an HIV protease inhibitor, you are going to have issues, at least with most of the HCV protease inhibitors, particularly cimeprevir. In the setting of the ABRI-3D regimen, you can use, however, boosted atazanavir. Remember that the ABRI-3D regimen is co-formulated with 100 milligrams of ritonavir, so you cannot then give your ritonavir separately with your HIV regimen, so the patient has to take HIV drugs and hepatitis C drugs at the same time to use the ritonavir boosting, not only for getting adequate hepatitis C drug exposure, but also for boosting his respective atazanavir. Now, let me just summarize some of the main pivotal trials and making the point that it really looks as if the overall response rates in co-infection are really the same as in mono-infection. This is the IN4, ladipasvir sofosbuvir for 12 weeks, a large patient number, over 300 individuals, and you can see that 96% cure rate was really the same for naive, experienced, cirrhotic or non-cirrhotic patients, so really resembling very high efficacy in that particular trial. The same was true for decladisvir sofosbuvir in the 12-week arm, whether you were naive or experienced. Great response rates, 96, 98% respectively. There was an 8-week arm, which only had 76% cure rate, suggesting that this was not working, and that's one of the main reasons why in the American guidelines there's no recommendation for shorter treatment durations for co-infected individuals. But note that in all patients who had a low viral load, below 2 million, all patients cured with the 8-week arm. So I think it is a question of high viral load or low viral load, and there may be room for shorter treatment durations in patients who have lower viremia. This is the Turquoise 1, the 3-drug AbbVie regimen plus ribavirin, 12 versus 24 weeks. There was no need for longer treatment durations. Cure rates again way above 90%. Note there was a little bit of leveling off towards the end, which was because 2 patients got reinfected. So one of the peculiarities of co-infection trials is that because a lot of MSM are included into these trials, you do see a lot of reinfections occurring, and you really have to think of that, obviously, in the conduct of these trials. So looking at the treatment options, I think right now for genotype 1 and 4, many different options are available. Obviously, as pointed out by the speaker before me, for genotype 3, that is where we really need more options, and obviously the pangenotypic regimen, which has been introduced, the valpatisvir, sofosbuvir could be one option, and others are there following up. A little bit on real-world experience, because obviously you always wonder, well, clinical trials search for certain patients. How does that all transcend into the reports back from real-world cohorts? And this is the German Gecko cohort, which has over 1,300 patients included. It includes mono and co-infected patients, and you can see that the response rates were on average over 90%, and that included HIV patients just as well as other more complicated patient groups, including cirrhotic, pretreated, and diabetic patients. And even the 8-week treatment arm, which is something which has been done in Germany, also for co-infected patients, showed excellent response rates. There's real-life data from France looking really at patients who had lined up with more advanced fibrosis, 67% cirrhotic, 2/3 treatment experience, and again, for the various regimen employed, you can see excellent response rate over 90%. So really telling us that what we see in clinical trials can be easily repeated in the clinical real-life setting. There's one recent presentation from the Spanish group looking at HIV, HCV co-infected patients and their response compared to mono-infected patients, describing that there is a somewhat lower response rate. They saw a little bit more relapses in the co-infected patients, but note that the patient population was very different. There were more IV drug users in the HIV group. There were more null responders and cirrhotic patients. So by enriching for unfavorable host factors, that may explain the differences observed. I think we would all agree, though, that 95% cure rate in a real-life cohort are excellent data, and so that shouldn't prevent us from using these therapies. How to treat after DAA failure, I think that's also very important because we're getting some information now, and this is looking at those very few 9 patients who failed in the IN4 trial. So those patients were then retreated after failing 12 weeks of soft litisphere. You could say, well, they're most likely to have resistance. Is that going to work? And they were treated for 24 weeks, so treatment duration was extended, plus ribavirin. And I think what is fascinating is that 8 of 9 patients actually went on to cure hepatitis C infection, telling you that even recycling the drugs is an option, obviously, in this particular patient group, and I think that is fascinating. New drugs on their way. Just to complete the list of co-infection studies, the Giuseppe-Elbesphere combination, which is already licensed in the US and will come to Europe and other places shortly. Again, 93% cure rate overall, so clearly an alternative. Note that in this trial there were also several reinfections, so obviously that has an impact on your full SVR analysis, but really reminds us again about counseling and preventing reinfection in our patient groups. Note that of the patients who failed, there were only a few who had baseline mutations, so the impact of mutations, at least in this co-infection cohort, was not found only in the overall complete analysis of all genotype 1 patients from the entire development program. The Astro-5 study is the soft hepatosphere study in co-infection, and again here you see excellent response rates for the various genotypes included, and particularly for genotype 2. This offers a ribavirin-free approach, and obviously for genotype 3, this is the first pangenotypic agent, I think, other than soft cladosphere, which offers potential good response rate in that more difficult to treat patient population. So in the end, can we change the epidemic? I think all of this depends on how many people are diagnosed. So with increased efficacy of therapy, it really depends on the more people you screen, the more people you treat, the more likely you will be to shape the curves of liver-related mortality. And modeling has been done for various countries, and you can see that in France, already with a very active screening program and many patients receiving therapy, you already see a decline in patients dying from liver disease. You see that in countries like England, where access to therapy is extremely limited, the curve of people dying from liver disease is still increasing, and really telling you that you have the tools in your hand to shape that curve, and that's why we should use that correspondingly. The last point I want to make is really about the reinfection rate, and there was a presentation from the NEAT-ID cohort, which looked at 606 individuals who had acute hepatitis C and were either treated or resolved that infection spontaneously, and the reinfection rate after 3 years was 25%. So really telling us that there is a strong need of implementing prevention programs in the MSM population. So in summary, HIV-infected individuals, I think, remain at higher risk for fibrosis progression and hepatic decompensation, just because many patients start therapy too late and CD4 count has been low, and that drives fibrosis progression. That's the reason why hepatitis C therapy remains prioritized in most guidelines for treating co-infected individuals. Clearly, the application or the administration of HIV therapy is extremely instrumental in preventing further liver disease progression. HIV therapy needs to be considered when co-administered with hepatitis C therapy for drug interactions, and there are excellent websites which help you along that way. And clearly, I think the cure rates are the same, and pangenotypic regimens are on the way, so I think it's now for us to use these regimens in these patients. Thank you very much.